But first of all, we've got to think about these simple definitions. So what is a neoplasm? Well, a neoplasm is an abnormal growth of tissue which, if it forms a mass, is commonly referred to as a tumour. So, in other words, it's a new and abnormal growth of tissue in a part of the body and is especially a characteristic of a cancer. And there are two main types of a neoplasm or a tumour. They can be benign or they can be malignant. And so if we're looking at the differences behind that, a benign tumour actually is not a cancer. It's a malignant tumour that is a cancer. Okay, so that's the fundamental difference between them. Benign tumour, not cancer. Malignant tumour is cancer. And for each of these cases, as I do with all of my lectures, I just want you to have a look at this and just using the knowledge that you already have, press pause on this recording and just answer the questions. And in each case, we're really thinking about yes, no, for local or invasive and whether it spreads or not, so metastasis, so yes or no in each case. Thinking about growth speed, how fast can they be or are they often? The potential lethality, is surgery effective? And are they well differentiated? In other words, do they look like the tissues they're meant to, is really what we're thinking about there. So I just want you to press pause now and in each case, answer the relevant question. Okay, so we're going to go through these now. And first of all, if we're thinking about a benign tumour, is this local or invasive? Well, it's local. It does not invade or destroy tissue. So it's local. If we're then looking at a malignant tumour, that's invasive. It can be locally invasive or it can spread elsewhere. So do we get metastasis? No. Benign tumours, generally they don't spread. Whereas a malignant tumour, yes, it has the potential to spread. Doesn't mean it definitely will, but it has the potential to spread just because of the way it develops. Growth speed. Benign tumours are generally slow. Malignant tumours, they can also be slow, but they can also be rapid. Lethality. So how nasty are they? They're only lethal in narrow spaces, your benign tumours. Okay, but they can be, so in terms of that lethality, they can be lethal, obviously, if they compress on other structures, such as blood vessels, for example, or nerves, for example, within the brain. And a malignant tumour, it's often lethal. It can spread to lots of different places and start to take over those tissues. Is surgery effective? With a benign tumour, yes, they're generally easy to remove and they haven't spread anywhere, so you just have to take them from one place. Malignant tumour? No, they often recur after surgery. Okay, they're a lot more invasive and therefore they're more likely to recur. Are they well differentiated? Well, benign tumours, yes. They look like the tissues from which they arose. They are differentiated. They look like the proper tissue. Malignant tumours, no. They often change or new ones are made so that they no longer look like the tissue from which they arose in the first place. So they are not well differentiated. So thinking about that term differentiation in as a cell type becoming or changing or being expressed within a tissue in its appropriate structure and therefore generally speaking function. Whereas if they're not differentiated, they're not performing the function that they're meant to. They don't look like the tissue that they're meant to be. So again, this is just a summary of those different areas. And so when we're looking at benign tumours, they're generally self-contained and localized, and they have, as you can see here, a well-defined perimeter. They tend to grow slowly, and they tend to grow outwards from a central mass. So you can see this in this diagram. They are, of course, dangerous when they compress surrounding tissues. For example, a benign tumour near a blood vessel can restrict blood flow within that tissue. In the abdomen, it could impair digestion. And in the brain, of course, it could cause paralysis. So that's your benign tumours. If we then look at the second one, we're looking at malignant tumours. These tend not to be self-contained. They may not compress the tissues around them, and their growth is very irregular, and they can invade adjacent tissues, adjacent cells and tissues. And sometimes they grow slowly, but they're also capable of very rapid growth. And finally, they're not localized. So in other words, as it says there, in a process of metastasis, so spreading, they can shed those cells which can enter the bloodstream, or they can enter the lymphatics at different locations, and they can therefore move to different places. So therefore they can establish malignant growth in a different type of tissue. For example, a breast cancer can spread to bone tissue, for example. So we're looking at the number of cancer cases, and this is in Australia, obviously. It's approximately new cancer cases. There's about 120,000 people per year. So it's a significant number of people. And if you're looking at these percentages, if you like, or the rates, you can see that males tend to get a greater case of cancers. And obviously you have less of them in the young. So they appear more often in the elderly, or as you're getting older, rather. It's the second leading cause of death in adults, second to cardiovascular disease. And even though there aren't many people or children who get cancer, it is a major cause of death within children, of course. If you're looking at the numbers or the proportions, as you can see from these diagrams, there's a lot more males who get cancer. And by the age of 85, about 50% of males will have or have had cancer, and about a third of females will have or have had cancer. And again, generally, women are more likely to survive cancer than men, so they generally do a bit better out of it. And that's shown by the 5-year relative survival rate. So 65% of women will still be alive after being diagnosed with cancer after 5 years, and it's 60% of men. And if we're looking at burden of disease, it accounts for about a fifth of that burden of disease. So it's quite significant. So if we're looking at the most common causes of cancer death, again, this is in Australia. The most common causes of cancer, of course, things like lung cancer, bowel cancer, prostate in men, breast in women, pancreas and melanoma, amongst others. We move down to lymphoma and some liver cancers. So that's how the common causes of death. That doesn't mean they're the most commonly diagnosed. The most commonly diagnosed are prostate, bowel, breast, melanoma and lung. So remember that the mortality rate isn't necessarily related to the incidence rate. In other words, how commonly they're diagnosed. And your most at-risk groups are obviously the elderly, because as you get older, you're more susceptible to cancer. Smokers, so we're looking at lung cancer and specifically. Obesity, you may have a family history of cancer, which may make you more susceptible. And you may have high exposure to carcinogens. So that might be ultraviolet radiation, too much time in the sun or under a sunbed. Alcohol, ionizing radiation, some viruses and bacteria can also lead to cancer. In particular, if you're thinking about human papillomavirus and cervical cancer, which many of you will have been vaccinated against. And of course, screenings are also very useful because screenings can pick up cancer sooner, and therefore the treatment can be potentially more effective. For example, melanoma, people are often going for those skin checks, cervical cancer with smear checks, and breast cancer. So screening is a very important tool in picking up cancers early. But of course, what you do need to know, you need to know the cancer type. So this is in your learning outcomes. So you need to know about them, and you need to know them according to their site of origin. So we're thinking about carcinomas, okay? We're thinking about endothelial cells, and we're thinking about epithelial cells, the cells around tissues. And this is it benign or malignant? This is malignant, okay? And epithelial cells are actually the most susceptible cells to cancer because they are exposed and they are rapidly dividing. And as they rapidly divide, they have a higher chance of mutating and therefore forming cancer cells. You then have sarcoma. So sarcomas arrive from your connective tissues. So for example, your fat, your muscle and your bone. And again, they are malignant. So sarcoma, malignant. Carcinoma, malignant. You then have adenomas. They're glandular, so from hormonal glands, for example, or from ductal tissue, and they are benign as a general rule. You then have adenocarcinoma. It's got the word carcinoma in it. So again, it's glandular or ductal, but because it's got that carcinoma in there, again, you can think that equals malignant. You've got lymphoma from your lymphatic tissue, that's malignant. Leukemia from your stem cells in bone marrow, it's malignant. Melanoma, so melanocytes in skin, malignant. You have lipoma from your fat cells, again, that's benign, and fibromas, again, part of connective tissue, that's also benign. But it's really important that you know, and I want you to really take home this message, which bone tumour is malignant. Would it be osteoma or osteosarcoma? So have a look at the table, okay? Have a look, osteoma, osteosarcoma, it's got the word sarcoma in it. So is it malignant or benign? Pause it if you need to have a look at the table to work it out. Okay, so as you can see, hopefully, by looking up at the top, sarcoma, it arises from your connective tissue, which includes fat, muscle, and bone. We're thinking about a bone tumour, so it's osteosarcoma, because it's got the word sarcoma in there, which is malignant. Osteoma is benign. So remember that, osteosarcoma, malignant, osteoma, benign. So the questions we really have to start asking ourselves is, why do we get cancer? So remember what cancer is. Cancer is a group of disorders, malignant disorders, that cause cells to escape normal controls of cell division. Because remember, many of our cells are dividing on a regular basis to replace damaged cells, or just to replace damaged cells is often the reason, or cells that are worn out. So we need to keep making these new cells. And we're thinking about this in terms of cancer. You've got to think, right, we've got something wrong going with cell division, but what's happening in cell division? So if we just look at the bottom left, you can see when we're making new cells, the first thing we have to do, well, really, we have to make new DNA. And so here we have a double strand of DNA, okay? And what you will normally do if you're making new DNA, you will copy that, okay? So you'll copy that DNA to make more. So look up into the top right and you can see where I'm pointing now. You've got DNA replication going on. You've got one cell with a splodge of DNA, the correct amount, and then it makes DNA replication twice the amount. So that during cell division, you've actually got twice the amount of DNA that you require. Okay, and so then what happens? We've DNA replicated. Then we need to divide the cells because we've got double the amount of DNA that we need. And then the process of mitosis happens. And that's when the cell, as you can move along here through mitosis, divides into two cells, each cell with the correct amount of DNA within it. And of course, mitosis, the process of mitosis, is controlled by proteins, and proteins are encoded by your DNA. So look at this bottom one. Here's your DNA. DNA is transcribed into RNA, messenger RNA, and that's then translated into proteins. So DNA is converted into proteins. Proteins are encoded by your DNA. So therefore, mitosis is controlled by your genes. In other words, mitosis is controlled by your DNA. So it's a really important concept to understand. DNA makes proteins. Proteins control DNA replication and mitosis. Therefore, this whole process is controlled by what is written in your genes, what is written in your genetic material, what is written in your DNA. So therefore, if your DNA becomes altered, so it becomes mutated, you may make too many new cells because you can no longer control this entire process of cell division. It might become uncontrolled and you make loads and loads of new cells when you don't want to. Therefore, making uncontrolled cell division, you're making too many, that leads on to a tumour. So what we're going to do now is we're going to start to think about the difference between necrosis, which is where we get cell death, okay, in an uncontrolled way, and then where we get programmed cell death, which is called apoptosis, where it's controlled within a controlled environment. So as I've said, necrosis is uncontrolled cell death. For example, if you have myocardial infarction, you'll get some myocardiocytes will die in an uncontrolled way. So this is necrosis. So here we have normal cell. You then get uncontrolled death. You start to get, doesn't matter too much what happens, but you start to get uncontrolled cell death and you get release of all the contents. So you get necrosis, so it's uncontrolled. So basically the contents leak out. In contrast to this, apoptosis, which is shown on the right-hand side, is cell death in a controlled way due to normal, healthy processes. So necrosis happens when we don't want necrosis to happen, it's uncontrolled. We want apoptosis to occur because that is controlled cell death. And it is a normal process. Okay, so it is a form of process that is generally triggered by normal, healthy processes in the body, for example, age. And necrosis, remember, cell death that is triggered by external factors or disease. So that might be myocardial infarction, it might be trauma, it might be infections. And of course, if we're getting controlled cell death, apoptosis is controlled by your proteins. And remember, your proteins are encoded by your DNA. So again, anything that changes your DNA can therefore alter apoptosis. So again, if your DNA is altered, you may not be able to kill your cells properly, And if you don't kill them properly, they may keep dividing because you're not killing them when you're meant to be killing them. So that again may lead to a tumour. So the next question is, why do we get cancer? Well, again, thinking about this, we're thinking about the genetic alterations. So we're thinking about DNA mutations. And it's these genetic alterations that cause all of the cancers. We don't get mutations in proteins just because the proteins change. We get changes in proteins because the DNA changes and the DNA makes those proteins. So if you have a mutation in a gene that then causes continual cell division, you will get uncontrolled cell division. If you have a mutation in a gene that usually stops cell division but no longer does that, you will also get uncontrolled cell division. So most mutations that cause cancer occur in genes that control cell growth and cell mitosis. So in other words, they're in genes that will stimulate cell growth and then we keep making them, or they might be in genes that inhibit cell growth. But when you get a mutation in that protein, or in that gene rather, it no longer inhibits that cell growth. And of course, as I said, it's epithelial cells that are often most susceptible because they divide the most. And that's because the more often a cell divides and copies itself, the more chances there are of making cancer cells with altered DNA. For example, you don't see heart cancer very often as these cells don't replicate, so there's little chance of errors occurring. So therefore, the more cell divisions you have, the more likely errors are to occur. And only a very small fraction of any cells that do mutate ever lead to cancer. And there are lots of reasons for this. Okay, so we make lots and lots of cells every day that are in essence, in inverted commas, cancer cells, that are abnormal cells. But there are several reasons that we don't ever lead to cancer, and that's because those mutated cells have less survival capability than normal cells, and they just simply die. Only a few of those mutated cells that do survive become cancerous, because even most mutated cells still have normal feedback mechanisms in place that prevent excessive growth. And also, you've got to think, those cells that are potentially cancerous are often destroyed by the body's immune system before they even get the chance to grow in a cancer. So there are lots of places or lots of reasons why we don't get cancer cells and cancer developing more regularly. So remember, other key points: cell replication and cell division, they occur in what's called the cell cycle. Okay, so there's a cycle that goes on where DNA is copied and then the cell is copied, if you like, is replicated, is divided. And there are lots of checkpoints there. So there are proteins that check the DNA at various DNA damage checkpoints. So for example, they have checkpoints when at normal metabolic roles, when the first growth phase. They check when the DNA is being copied. So during DNA replication, there are checkpoints where basically there are proteins that check that that DNA hasn't been mutated. And then when you're preparing for mitosis, which is when the cell breaks into two, okay, so cell division, there are various DNA damage checkpoints there. And so these checkpoints, there are proteins that are checking the DNA at these points to make sure the DNA is not abnormal, to check that it hasn't been copied abnormally. So in other words, what we're saying is damaged cells are basically repaired whenever possible. Okay, so the body is very, very clever. It can repair damaged cells. And so therefore, if you think about it, if an error occurs to the DNA, because it is checked at damage repair points, then repair is attempted. So you'll have a healthy cell, for example. The DNA may get damaged, and we'll talk about how DNA gets damaged later on. You then attempt to repair that damage, and if it gets repaired successfully, you have a nice healthy cell. If the damage can't be repaired, then the cell basically undergoes apoptosis, programmed cell death, controlled death. The errors can't be repaired, the cell shrinks, and basically you break down the cell in a controlled way, and it's engulfed, the remains are engulfed by phagocytes. So that's basically what happens. If repair fails, cell apoptosis occurs, and we're sacrificing the cells to save the body so we don't turn into a cancer. But that repair or the apoptotic processes, they don't always work. And if they fail in their processes, the damaged cell can encroach onto other cells, it can migrate to other parts of the body, And some of them can even generate their own growth signals, so they can release factors that stimulate the growth of themselves and stimulate the growth of new blood vessels, so blood vessels can come to them and deliver lots and lots of nutrients. So what happens there? Again, similar diagram, healthy cell, DNA becomes damaged, attempt to repair it, attempt is successful, we have a healthy cell. If we can't repair it, normally we'd go down apoptosis. But if for some reason genes involved and DNA involved in apoptosis have changed so that apoptosis no longer occurs, we get, in other words, we get impervious, it's impervious to the apoptotic signals, a cancer can develop. Okay, and it may release a variety of growth factors that induce the synthesis of new blood vessels, as I previously said. So we've got a nice, rich blood supply coming into the cancer, so it gets the nutrients it needs and it can continue to divide nice and fast. So in these cases, your cancer may develop, and as I said, you may get growth signals released. They may induce angiogenesis, which is the synthesis of new blood vessels. So we're delivering nutrients and oxygen to that cancer cell mass. So what are the types of genes that are involved in the cell cycle? So when we're thinking about it, during the cell cycle, we're getting replication of our cells. We're getting new cells being made. And what we have cells that stimulate that genes that stimulate that process. These are called proto-oncogenes. So they stimulate growth. And at the same time, we have tumour suppressor genes. They inhibit growth. So in other words, there are some proto-oncogenes that make proteins that stimulate growth, and then we have tumour suppressor genes that make proteins that inhibit that growth. So we can control the number of cells that we're making in an appropriate way. And as I said, that allows you balanced and normal growth. So again, I just want you to pause the slides now for a couple of seconds and fill in this table. So we have a proto-oncogene and a tumour suppressor gene. And all I want you to think is I want you to write increased, decreased, or no change for each of the little boxes. So for example, the effect of normal gene on cell division. What does a proto-oncogene? Does it increase cell division or decrease? Tumour suppressor gene, increase or decrease? And then I want you to think if you have a mutated proto-oncogene or a mutated tumour suppressor gene, what effect is that going to have on cell division? So press pause and just think increased or decreased in each case. Okay, so effect of the normal gene on cell division, proto-oncogene, as it says in the title at the top, that stimulates growth, so it's increased. Tumour suppressor gene inhibits growth, so it decreases cell division. Now, if that proto-oncogene is mutated, what's going to happen? Increased, even more stimulation of growth. And if your tumour suppressor gene is mutated, it no longer inhibits growth, so therefore we get increased growth, so increased cell division. Therefore, basically, overactivity of proto-oncogenes, which actually go on to form oncogenes, that will lead to increased cell division and potentially cancer, and underactivity of tumour suppressor genes can also lead to cancer or tumours. But it's also interesting to note that viruses can also introduce an oncogene or alter a proto-oncogene. Because remember what happens? Proto-oncogene is the normal gene. So remember what's happening. A mutation can activate a proto-oncogene, which is the normal gene, therefore turning it into an oncogene, which is the cancer-causing gene. Okay, so remember, proto-oncogenes are the normal, healthy version of genes that then go on to make proteins that stimulate cell division and cell growth. So then we're thinking about viruses. So viruses in themselves can introduce an oncogene into our genetic material, or they can alter a proto-oncogene, turning it into an oncogene. And examples include hepatitis B and C, which can go on to lead to liver cancer. Epstein-Barr virus can lead to lymphoma, and human papillomavirus can lead to cervical cancer, which is, like I said, one of the vaccinations that women often have, and now boys will often have human HPV vaccinations as well to help prevent the spread of HPV to females in particular. So remember what happens. Proto-oncogenes, they speed up the cell cycle. They stimulate cell division. So they're acting as growth factors in the cell cycle in growing tissues. And a good example of this is the MYC gene. So MYC is a proto-oncogene, so it's a normal gene, and it enhances the synthesis of about 15% of all of our genes. So it's a huge number of genes it enhances the synthesis is. So you can imagine anything that enhances mutations in the MYC gene that stimulate MYC will actually cause an amplification of MYC, and you see an amplification of MYC occurs in about 70% of human cancers. That includes about 90% of your gynecological cancers, for example, uterine cancer, 80% of your breast cancers, and 70% of your colorectal cancers. And so therefore, MYC is contributing, not a direct cause, but it's contributing to about 6,000 cancer deaths annually in Australia. So it has a significant effect. And this next bit is just to remind you, a proto-oncogene, that's the normal gene that stimulates growth, okay? So it's controlled. You get a mutation in that, it may form an oncogene, that's the cancer-causing one. You now get rapid cell division leading to cancer. So proto-oncogene is the normal gene. When it's been mutated, it forms an oncogene, which can lead to rapid cell division and then potentially onto tumours and cancer. And of course, we've got the tumour suppressor genes, and these are the ones that slow down growth. They act as brakes, so therefore they're helping to inhibit or prevent cancer from forming. And there are a couple of good examples of this. So P53, that is a suicide gene that causes apoptosis of mutant cells. So it's a very important gene. If you have a mutant cell, this P53 is activated and it acts as a suicide gene. It induces apoptosis. And for some viral proteins, so virally encoded proteins, can actually bind to P53 and inactivate it. And so therefore the mutant cells can continue to divide. And the one that you might have heard of is the BRCA genes, so BRCA1 and BRCA2. But these genes are basically, they are DNA repair genes. So they're very, very important. They are acting at those checkpoints, checking the genes, and therefore and then going on to repair them. So if you have a tumour suppressor gene, and you get a mutation in that, you can no longer repair the DNA damage that's occurred, or you may not get as much apoptosis going on. And so if you don't get as much apoptosis, programmed cell death, then you get more cell division, leading to potentially a cancer. And if you can't repair the DNA because you may have a BRCA1 mutation, again, you can no longer repair the DNA. It's therefore inappropriate DNA, which may continue to replicate and go on to cause cancer. So about 12% of women will develop breast cancer during their lives. So it's a reasonably high number. But 72% of women who inherit a mutated BRCA1 gene will develop breast cancer by the age of 80 years. So you can see the significant influence of having a mutated BRCA1 gene on the development or the potential development of breast cancer. And about 10% of all breast cancers are linked to mutations in the BRCA gene. It's interesting to note as well that about 1.5% of the population of women in the general population will also develop ovarian cancer at some point during their during their lives. And interestingly, in the most recent estimates, about 40 to 45% of women who inherit a mutated harmful BRCA1 gene or a BRCA1 mutated gene will develop ovarian cancer. Okay, so that's basically saying we're going from 1.5% of the population up to 45% of the population because of that BRCA1 gene. So it's mutated BRCA1 gene. But it's very important to note, BRCA1 is a normal DNA repair gene, but if you have a mutated BRCA1, that means it may not be able to repair damaged DNA effectively, which may go on to lead to cancer. And that leads me to my review question. So again, as usual, have a little look through this question and answer true or false in each question for each answer. So again, press pause, have a look through, true or false in each case, as well as saying true or false. Think to yourself, why is this true? Why is this false? So press pause and then I'll go through it in a second. Okay, so BRCA1 is a tumour suppressor gene associated with cancer. What does this mean? True or false in each case? The BRCA1 gene causes cancer. That is false. The BRCA1 gene does not cause cancer, it repairs damaged DNA. All breast cancer patients have a mutated BRCA1 gene. That is also incorrect. About 72% will develop breast cancer if they have a mutated BRCA1 gene in their lifetime. The BRCA1 gene is a proto-oncogene. This is incorrect. Again, it is a tumour suppressor gene, and tumour suppressor genes, remember, inhibit growth. The BRCA1 gene is only present in women. This is also incorrect. It's also present in men. And mutations in men can lead to increased risk of breast cancer, okay, just as in women, prostate cancer, and it increases their risk of melanoma, so skin cancer as well. The BRCA1 gene is a normal gene that helps prevent cancer in males and females. This is correct because it helps to repair damaged DNA. Okay, so the next bit that we're going on, we're going to go through the different phases in cancer development. Because any neoplastic changes, so neoplastic changes, they're not adaptive and they're not reversible. And so if we're looking at what's actually going on, we go through a variety of different stages. So we have our normal cells, and this is just looking at a lung cell, and you can see these are if you're looking under normal, you can see appropriately differentiated, and you can see the little cilia that are present there, so the little hairs that are helping to clean out the lungs. And so when we're going into the processes of pathogenesis, you get that irritation, you get a trigger that causes the initial damage. And when you get those triggers going on, you get what's called metaplasia. So you're getting replacement of one mature cell type by another due to the constant stressor present. In this case, we're thinking about smoke and lung cancer. So in other words, at this point, we're getting abnormal changes in size and shape and organization of cells within a tissue. In other words, we're getting changes in structure. And this indicates that mutations have occurred, and these mutations have occurred due to the presence of a continuous stressor, for example, smoke, like I said. So in other words, these cells have adapted to the stressor. And it makes the next stage, which is dysplasia, which you can see there, much more likely. So what is dysplasia? This is where we start to get an abnormal change in size, shape, and organization of mature cells following further adapted changes. But in this case, those adapted changes have gone wrong. Okay, so it's strongly associated with cancer development. And these dysplastic changes, they're likely to be adaptive changes that have gone off course, meaning that if the inciting stimulus, in this case smoke, is removed early enough, dysplastic changes may be reversible. They may progress to cancer, but they may regress back to normal cells. So like I said in the example here, you can see the cilia which I saw under the normal aspect. Let's have another look at the little diagram there. The cilia there of epithelial cells are damaged and paralyzed by exposure to cigarette smoke. And these changes cause a local buildup of mucus and reduce the effectiveness of the epithelium in protecting deeper, more delicate portions of the respiratory tract. So we've got a trigger, some smoke that's causing some damage. We're getting replacement of one mature cell type by another. We then move on to dysplasia, where the adaptive changes are going wrong. And we then move on to anaplasia, which is there. This is where your normal function is completely lost. We've hit the irreversible phase, and this is a hallmark of malignancy. And as you can see, you may be getting changes in c-MYC at this point, and the MYC gene, and the p53 gene that we've already talked about. And this goes on to lead to neoplasia. So in other words, we're getting cell proliferation control is lost, and a tumour is formed. And just so you have a definition, because you need these definitions, pleomorphism, this is basically tumour with a different cell types as a result of multiple mutations over time. In other words, you're getting bigger abnormal cells. And something that's fairly well known and fairly well established is that cancer tends, as a general rule, to require or involve multiple mutations. And what they say, if you're looking at a ballpark, they usually say around 4 to 7 mutations are required for the development of cancer. So if we're just looking at this little diagram, you can see over time you've got normal cells going on, and over time you get mutations occurring. And that, for example, might inactivate suppressor genes. And then therefore your cells start to proliferate. And you might get a benign tumour cells grow only locally and can't spread by invasion or metastasis. Then as you get more mutations, your mutations may start to inactivate your DNA repair genes. And your proto-oncogenes may start to mutate to oncogenes. And so now you might start be getting malignant cells invading neighbouring tissues. They may enter blood vessels and the lymphatics, and they may metastase to different sites. And then you get more mutations, more genetics instability, and more in-depth metastatic disease. So you can see how mutations can be additive and progressive. So you've got lots of triggers that are causing those mutations to occur in the first place. Some of those examples you'll know about. Things like tobacco, so smoke, and alcohol within the mouth, for example. Low fiber, high fat diet, if you're thinking about the GI tract. Chronic infections, so for example, hepatitis B virus, you're thinking about the liver. Air pollutants, particularly within the lungs, and UV radiation, you might be thinking about the skin. So all these are potential triggers. So what that's telling us is that lifestyle, biological, and chemical factors are all potential triggers or risk factors for cancer. So remembering that all these mutations that are potentially occurring, they are acquiring as one ages, which is also why we start to get more cancers as we get older. But they are also dependent on our lifestyle risk factors. Like I said, tobacco, alcohol, the diet, pollutants, UV radiation. So there are lots of things. And a lack of exercise can also be a lifestyle risk factor. So the key point about the beginnings of cancer, or the beginnings of a tumour more accurately, is that we have initiators or triggers. And these triggers alter the genes involved in DNA replication, DNA repair, and apoptosis. So for cancer development or tumour development, we need those initiators in the first place, those triggers. So those triggers, what they do is they can potentially bind to DNA, or they can damage DNA and cause irreversible mutations to that DNA that increase the risk of cancer. Like I said, those initiators can include tobacco, alcohol, for example. So what we've got, if we have an initiator, that initiator, such as your tobacco and your alcohol, they cause irreversible damage to your gene. So they're causing a gene mutation. We are now susceptible to what's called promotion. Okay, so we've started the whole process. We've got an initiator. We've now got promotion. So we now have susceptible to promotion. So a promoter can now induce that gene expression. So as the initiator causes the mutation in the first place, it's a promoter that can initiate gene expression. And some of those promoters can include hormones, so estrogen, for example, drugs, and chemicals. There are lots of different ones. So an initiator causes the mutation, a promoter induces that gene expression that's been the result of the initiator. And that's why we start to get abnormal replication of cells. So what we got, once a cell has been mutated by an initiator, it is susceptible to the effects of promoters, which can induce cancer development. And they can induce that cancer development by different ways. They can alter cell-to-cell communication. So cells talk with each other. They're talking to say, hey, stop dividing, hey, continue dividing. And basically that altered cell communication might just say, keep dividing. Okay, they can release lots of growth factors. They may produce free radicals, and they may cause cell division. We've talked about tumour suppressor genes. We've talked about activating genes, so MYC, for example, that stimulate growth. So there are lots of mechanisms, there are lots of things that can promote that. So remember, we need an initiator to cause the DNA damage, and then a promoter to kick it all off. So a good example of a promoter okay, is estrogen. So estrogen can act as a promoter in some breast cancers. So if we look at this breast cancer, this is an estrogen receptor negative breast cancer. So what you can see, you've got a mutation that's occurred. That's the little green bits down there, okay? And the cell proliferation is not controlled by estrogen. There's no estrogen receptor there. If we look on this one, this is an estrogen receptor positive breast cancer. So in this case, there's an estrogen receptor that estrogen binds to, that can then bind to the DNA and induce cell proliferation. So in other words, cell proliferation in this case is controlled by estrogen. And about 70% of breast cancers are estrogen receptor positive. So therefore, they are stimulated breast cancers to grow and spread. And tamoxifen, so that's a commonly used drug, is a competitive inhibitor of the estrogen receptor. So it binds to the estrogen receptor. So which type of breast cancer is it used to treat? It's used to treat the estrogen receptor positive breast cancer, which is about 70% of breast cancers. And it's often used after people have been treated for breast cancer by having the lump removed, for example. They'll often be given tamoxifen at that stage. And thinking about estrogen in terms of breast cancer, a similar principle is with testosterone. Testosterone can act as a promoter in some prostate cancers. Okay, so it binds to a testosterone receptor within the prostatic cells, inducing prostate cancer. So if we're thinking again further, so we've thought about initiation, we've now thought about promotion, and then you've got to think about progression. And progression is characteristic of malignant tumours. So you may have a small localized tumour, it releases lots of signaling molecules, induces angiogenesis, so the lots of blood vessels are now being made into that tumour. And progression depends on the degree of angiogenesis, the amount, and vascularization. So in other words, the amount of new blood vessels that have been made. And many cancer cells, these signaling molecules, they make these chemical messengers, such as VEGF, that's vascular endothelial growth factor. So you're making vascular endothelial cells, which make up your blood vessels, and they stimulate angiogenesis. And so obviously, if you've got a blood vessel moving into the tissue, that makes it more likely that those cells can enter the bloodstream and therefore move to other areas. And so a growing tumour may therefore spawn what are called pioneer cells. These invade into or penetrate into adjacent tissues, and then they can move into distant sites via blood system or the lymphatics, and that's metastasis, where they can then go on to form new colonies. So that's your secondary tumours. So your examples would be in breast cancer. Breast cancers often spread to the bone. So your secondary tumour is in the bone in that case. And that's all that this diagram is showing. So first of all, if you're looking at number one, your cancer cells can invade, first of all, the surrounding tissues and vessels. They can then enter the bloodstream or the lymphatics and spread to a new location where they can then go and grow. That's your secondary tumours. So, a couple of review questions for you. So again, pause this question, and in each case, true or false. Okay, let's go. So in the process of oncogenesis, which of the following are correct? Remember, oncogenesis, is the process through which healthy cells become transformed into cancer cells. Okay, just so you've got it clear what oncogenesis is. It's a process where healthy cells are transformed into cancer cells. So which of these is true in the process of cancer cells being made? There is an uncontrolled increase in cell number due to increased cell division and or decreased apoptosis. Yep, that is correct. You may get increased cell division, or you might get decreased apoptosis, so decreased killing of cells. And if you're not killing as many, you're getting more that are growing. Changes involved in oncogenesis involve metaplasia, dysplasia, anaplasia, and neoplasia. Correct, those are the four phases that we talked about earlier. First of all, metaplasia, then dysplasia, anaplasia, and finally you form your neoplasm. Normal cell function is lost in anaplasia with a lack of specialization or differentiation. Yes, that is correct. That is when your normal cell function has been lost. So in other words, the cells are no longer appropriately differentiated because they can't do what they're meant to be doing. and therefore it's the hallmark of tumours. Pleomorphism, which is basically where you have different shapes and sizes of cells, is uncommon in most tumours. False. It's very common for cells to become pleomorphic in tumours. Angiogenesis is advantageous to tumours as it allows delivery of nutrients. True, of course it's an advantage to have more blood vessels because you can stimulate the delivery of nutrients to those tissues. So the last little bit we're going to go through those clinical manifestations of cancer. So what are some of the signs and symptoms? So the early stages of cancers tend to be asymptomatic. So there is a delayed symptom development and also a diagnosis. It's slower to diagnose if you're not getting the symptoms. The symptoms of cancer are quite specific to each cancer, but there are some general symptoms, signs and symptoms that people get. So people will often get pain and obstruction because tumours can compress on tissues and stimulate nociceptors. You may get referred pain. For example, a swollen liver can cause pain in the right shoulder, even though the liver is under the ribs on the right, and that's just because the liver presses on nerves that end in the shoulder. You may get cachexia. Now, cachexia, for you guys, if you don't know, it's where you get weakness, and you can see that in the image there. Weakness and wasting of the body due to severe chronic illness. So in other words, you're getting muscle atrophy, you're getting fatigue, and you're getting weakness. You may get anemia, a lack of red blood cells, leukopenia, a lack of white blood cells, and thrombocytopenia as well. So all of those may decrease depending on where the tumour may be, but of course, you've got a lack of nutrients and you're often affecting the bone. And by the same token, if you've got a lack of white blood cells, you get immune suppression, and therefore you're more susceptible to infections. And as I said, you may get pain and obstruction because a growing tumour can exert pressure on surrounding tissues, organs and nerves. You may get visceral stretching due to growth. Remember, viscera is your internal organs. And you may get invasion of structures that contain nerve endings, stimulating nociceptors, for example. And by the same token, you may well get tissue injury and inflammation. You've got tissue growth, cell growth. This can lead to damage and inflammation. So I'd mentioned cachexia earlier, or cancer cachexia. So what is it? It's really just a syndrome where you get progressive weight loss. So people lose both fat and skeletal muscle. And some of the symptoms of this are anorexia. Remember, anorexia is just referring to reduced food intake or starvation. You may become full very, very early. Okay, you may become anemic, and you may get fatigue and weakness. So cachexia is it's a wasting syndrome. It may be due to a combination of reduced intake of nutrients and increased metabolic rate, and it depends on the cancer in a lot of ways. And so basically, about 50% of patients will develop cachexia or cancer cachexia. So they get a mixture of anorexia with cachexia, which is your wasting syndrome, which leads to cancer anorexia cachexia syndrome because you're not eating as much and you also have wasting syndrome at the same time. And so, and as a general rule, involuntary weight loss in cancer patients, it can't be reversed by normal nutritional support. So you just can't give the appropriate nutritional support that you would like. And so basically you work through the stages. So in the early or mild stages, which are shown in this little arrow, patients may only notice a slight loss of appetite with little weight loss. But as the condition gets worse, individuals will start to notice more weight loss and often eat even less. And then when we start to reach the really severe stages, muscle wasting becomes obvious, you can't perform your routine activities, and the condition may be resistant to normal treatments such as dietary supplementation and nutritional support, which then obviously starts to lead to severe muscle wasting, severe cachexia, and eventually end of life. But of course, the lack of protein that people will have within their diet as they're muscle wasting, they're not getting it in their diet, leads to reduced plasma albumin levels, which is the main protein in your blood, as we previously talked about. And of course, that means you may get reduced hormone and drug binding. And if people are taking drugs, it can lead to potential drug toxicity because of the reduced drug carrying capacity within the blood. So other common clinical manifestations of cancer, including anemia. Again, this may be due to malnutrition, so decreased iron in the diet, or the B vitamins. So you get a decreased red blood cell count, which means you have a decrease in your oxygen carrying capacity. So that leads obviously to lethargy and tiredness. You may get chronic bleeding. Okay, so that decreased red blood cell count may be because of that decreased iron and B vitamins. You may get chronic bleeding. It's not very much per day, 5 mils per day, because you can't clot as easily. So you've got your thrombocytopenia, so decreased platelets. So not as much clotting, so a little bit loss of blood. You may get decreased erythropoietin, EPO. That's made in the kidney. Okay, and that stimulates red blood cell synthesis in the bone marrow. You may get an adverse effects of treatment, so chemotherapy and radiation, they're going to stop rapid cell division, and that's occurring in the bone marrow, so you may get decreased red blood cell synthesis for that. And of course, some cancers invade the bone marrow, therefore they're taking up space and reducing red blood cell synthesis. So remember, in chemotherapy, it targets rapidly dividing cells, and that will hit your red blood cells, it will hit your platelets, hence why both of them may decrease. So you might get decrease in your red blood cell production. You may get slow replacement of the old red blood cells because of the effects of chemotherapy, or because cancers are taking up the space within the bone marrow. You get your thrombocytopenia, so your clotting is reduced. Therefore, that's what might lead to that chronic bleeding, just small amounts of blood loss per day, small amounts of red blood cell loss per day. And then your leukopenia, your decrease in your white blood cells, of course, which leads to susceptibility to infections. So leukopenia, like I've said, is decreased white blood cell count, leading to an increased infection rate or risk of infection. So here's your normal, here are a few white blood cells, and in leukopenia you can see you've got less white blood cells. So you can fight infections less effectively. Because of course, white blood cells, they're made in the bone marrow. So anything that disrupts bone marrow function decreases your white blood cell count. So exactly the same as for red blood cells. A tumour taking over the bone, or chemotherapy affecting white blood cells being made, for example. And of course, stress, and cancer is a very stressful disease, insomnia and a poor diet all reduce immunity. Okay, so all of those things are going to affect your immune response. And in cancer, stress is increased, insomnia is increased, and your poor diet is more likely, all of which increase that risk of leukopenia and therefore reduced immunity. And of course, in cancer patients, there are increased portals of entry, for example, in your cannulas, and therefore cancer patients are at high risk of bacterial septicemia, pneumonia, fungal infections, herpes simplex virus, cytomegalovirus infections. And because you've got a reduced immunity, they can be potentially much nastier than they would be in a normal patient. So infections can basically kill patients before the cancer does in some cases, just because of that reduced immunity. And patients are often given antibacterials, antivirals, antifungals as a matter of course to help reduce those chances of infections. So we talked about screening, and screening is a very effective way of getting your healthy groups and your at-risk groups so you can pick up cancer in its early stages and therefore more effectively treat them. So for example, you may have a clinical exam, a mammogram of breast tissue. You have a cervical scrapes for your pap smears for your cervical cancers. You'll have a skin check for your visual inspections for particularly of malignant melanoma, and a prostate, which may be a digital exam, or you can detect prostate-specific antigen within the blood, and that's increased in prostatic cancer, for example. And so if you're just looking at a mammogram, you can see a normal mammogram, then you can see a benign cyst, and then if you look on into the last one, you can see a cancer within the breast tissue. And obviously your specialist can distinguish between normal, benign cysts and cancers. And of course, in those cases, if you have something like that, a biopsy is required for diagnosis, but of course, a biopsy is also invasive. So the main forms of treatment also have very significant adverse effects. So obviously you have your surgery, your radiation, chemotherapy. Those are the main treatments for cancer. But of course, chemotherapy, if you're given that, chemicals given, these are very toxic to cancer cells and they target rapidly growing cells. So therefore, chemotherapy is generally very toxic to the body because we have lots of rapidly growing cells which are normal within our body. Epithelial cells, for example, red blood cells, for example. Radiation. So radiation targets specific tumours and therefore has milder side effects than chemotherapy, but it does kill normal cells. But like I said, because it's targeted, its side effects are less. You do have cryotherapy, so that uses liquid nitrogen, which is very, very cold, to freeze tumours, for example, some skin cancers, but it can also kill the pigment, and that's a side effect. And finally, you can use hormone therapy, so it uses hormones to reduce size of tumours. So that's used in prostate and breast cancer, for example. So really what we're thinking, radiation and chemotherapy, they kill your rapidly growing cells. But they do that by causing DNA damage. So they're targeting your rapidly dividing cells. And therefore we're leading to apoptosis. But of course, prevention is better than cure. So you want everything in moderation. Finally, just a couple of questions. Okay, in each case, for these two questions, I just want true or false in each case. So again, for this one, pause. Press pause, have a little look through it, and then press play again. Okay, so cervical cancer is linked with infections. Which statements are true regarding cervical cancer? Cervical cancer is linked with hepatitis B virus infection, and vaccines are available to help prevent viral infections of cells. That is incorrect. Hepatitis B affects the liver, and there are vaccines available. Human papillomavirus infection. Antibiotics can be used for treatment. That is also incorrect. Human papillomavirus does infect your cervical cells, but you don't use antibiotics for treatment. Human papillomavirus infection, vaccines are available to help prevent viral infections of cells. That is correct. So your vaccines, there are over 100 different human papillomaviruses, and the vaccines tend to hit HPV 16 and HPV 18, which are two of the main causes of cervical cancer, though there are other ones out there as well. Bacterial infection, antibiotics can be used for prevention. That is also incorrect. That's got nothing to do with cervical cancer at all. Next question. Which of the following are correct regarding cancer cachexia? Again, press pause. Okay. So I'll give you a clue. Only one of these is correct. So I want you to think, is it number 1, 2, 3, or 4? You may want to pause again to think only one of them is correct. Okay, number 3 is the only correct one there. So you get progressive loss of body fat and skeletal muscle in cancer patients. That's your cancer cachexia.